Started. Good morning, everyone. Welcome back to our weekly CMR conference series hosted at VCU. I'm happy to be presenting today on a topic that I am personally very passionate about. And I think as an institution, we have a number of people who have been invested in this exercise CMR technique. And so I'm happy to give an overview and talk people through the challenges that we've faced trying to use this technique and how we and other people have gotten around the challenges in the MRI environment. And just a reminder for everybody, these sessions are CME and MOC accredited, so don't forget to text the code on the screen to the number provided and claim your credit. You got to do that within 48 hours now, so they've tightened the timeline a little bit. Okay, so let me go ahead and share my screen. And okay, so here's my one disclosure. It's actually outdated, but it doesn't apply to this talk. So this is the overall outline of the talk for today. I'm going to give a little bit of an introduction and why we would even want to do exercise CMR, some of the challenges, and then considerations of what types of exercise modalities we can strive for in the MRI environment, the imaging sequences that can be or have been deployed following exercise, how it's been used in certain clinical populations, how it can be combined with other modalities, and then used for longitudinal assessment before and after some important time point. And then finally, just wrapping up with some future directions for the field. And so as an introduction, we in the audience are probably pretty well aware of all the different things that CMR can do. It is such a powerful imaging modality with its ability to offer the gold standard of structure and function, EF assessment, flow assessment for valves or vessels, scar assessment with late gadolinium enhanced imaging or parametric mapping, and then of course angiography. But really, we are oftentimes imaging a patient population who has symptoms. And if you ask them when they're just lying down, that's not typically when people tend to have their symptoms, whether they have heart failure or coronary disease or whatever it is. Lying at rest, patients are usually not symptomatic unless they're in NYHA class 4 stage. But you ask them to mow the grass or climb up a hill, that's when they start feeling their symptoms, and that's why they're seeking care in the clinic oftentimes. And so why would we expect necessarily that lying someone down supine at rest would show you everything that you need to see about the pathophysiology in patients who have exertional symptoms? And this goes for a number of things. I mean, not just CMR, but transthoracic echocardiography, right heart catheterization, all these things where traditionally the measurements have been made at rest. And I think what's become clear with other modalities, including right heart catheterization, is that you can fail to uncover certain pathologies like elevated filling pressures at rest alone in at least a subset of individuals. In that subset of individuals, you really have to provoke them with some kind of challenge like exercise to reproduce the conditions where they've actually got symptoms to uncover what is holding them back. And I really like this quote from Andre Lagersh and his team that says, to assess exertional breathless, you must exert the breathless. And I think that's just a really nice way to sum up the approach. And indeed, exercise-based testing or forms a basis for a number of conditions in the guidelines, such as stable ischemic heart disease, valvular dysfunction, prioritizing it as an endpoint for older adults, understanding that functional status is very important for quality of life and prognosis. So exercise-based testing is important in other areas. It only makes sense to want to bring exercise into the CMR environment and see what we can see with our advanced imaging modalities. Okay, that being said, there are some technical and logistical challenges that are unique to the MR environment, namely the massive strength of the magnetic field that's generated from the MR unit. Really, what's considered a safe distance from the bore of the magnet is this 0.5 millitesla or the 5 Gauss line. So there's sort of a decaying strength of the magnetic field as you go further and further from the bore of the magnet. And so anything that's got ferromagnetic material is at least strong enough to interfere with the image quality and or become potentially a projectile towards the center of the magnet, must be beyond this 5 Gauss line. And as you can imagine, most of our exercise equipment will then have this material, this ferromagnetic material, that becomes problematic if you have it within this distance. Not only that, most MRI units are not adequately equipped or staffed to run an exercise test. You need appropriate staffing and training, both with the MRI technologists, the nursing staff, exercise physiologists, mid-level APPs and or physician coverage, whatever you need to satisfy the recommendations for clinical exercise laboratories. And so the staff needs to be able to properly prepare the patients, screen for contraindications to exercise testing, and in the rare event of an emergency during an exercise test, be able to respond appropriately to that. Again, not every MRI unit is staffed in that manner, and so it requires some extra considerations in the staffing. Excuse me. So that being said, what different exercise modalities are possible in the MR environment with those constraints? Well, the first is just treadmill, which is what we're most familiar with, at least in America. The advantages of treadmills are that we have very standardized protocols, whether they be Bruce or modified Bruce or ramping protocols. We know if you walk 7 minutes on a Bruce protocol in America or Europe or Asia or wherever you are, we know what that means. 7 minutes on a Bruce protocol has widespread familiarity among clinicians, a well-established prognostic value, and you're more likely to achieve a true peak exercise challenge, particularly in the US. We'll go through why that's the case in a little bit. The major disadvantage is that treadmill units tend to contain ferromagnetic materials in the motor and the framing of the treadmill, and so you can't just bring that right next to a CMR unit. You have to think of creative ways to deploy the treadmill to exercise tests. And so this is a study from just over 20 years ago with Dr. Hunley's team, where they did put the treadmill right by the door of the scanner room. And so they were able to do a full Bruce protocol or whatever protocol of their choosing. As soon as the patient reached peak exercise, they would then have them briskly walk over to the bore of the scanner, lay down, shoot them inside the scanner. And so the distance between the treadmill and the CMR table, rather than right next to the treadmill, as we often do in the echocardiography laboratory, the distance was about 20 feet. So you have to choose your patients somewhat carefully, make sure that there's not going to be any issues with that transfer. But in using this approach, they were able to complete their images, their cinematic images for wall motion assessment, a mean of 61 seconds from exercise termination. This is their earlier experience, and you can see already there's an example of a patient up top where during rest and exercise, there's normal augmentation of LV wall motion. And then in a patient with ischemia, here they are at rest and here they are at exercise with the septal and anterior walls fail to augment. And so they're able to very precisely identify a wall motion abnormality. And then in a later publication, they now had 115 patients where they had used this approach to exercise testing. And with a blinded assessment of cardiovascular outcomes, they found that 90% of their individuals, they had full images obtained within 60 seconds of exercise termination. So the more experience they got as a unit, the more quickly they were able to achieve their imaging protocols and comfortably within the 60-second time limit that is typically associated or recommended for maintaining adequate sensitivity to detect signs of ischemia. The team out at Ohio State got very creative with their approach. They were able to come up with an approach where all of the motor of the treadmill was confined to the front of the treadmill, and so all the ferromagnetic material was right there. So if they positioned it just right, they were able to put the motor right here, and the rest of the treadmill spilled within the 5 Gauss line. But nonetheless, all the ferromagnetic material was out of the 5 Gauss line. And so in doing so, they were able to safely position the treadmill inside the MR room, and just reduce that distance between the treadmill and the MR table. And so here you can see it positioned. They've got it carefully taped off so that they don't accidentally move the motor too close to the bore of the magnet. And because they reduced that distance a little bit, they were able to, with 20 healthy volunteers, they were able to not only get wall motion assessment, cinematic imaging following exercise, but they were able to get perfusion as well. So they would get their cinematic stack, which they achieved about 45 seconds after exercise, and then they would push a bolus of gadolinium-based contrast through a peripheral IV and watch the first pass perfusion to screen for any perfusion defects. And they found they were able to do that on average about 57 seconds after exercise termination. And then they got even more creative, and they completely removed the power unit and the motor from the treadmill itself, and through a hydraulic system, they powered the belt itself. And so that meant that they were able to have the power unit and the motor inside the control room, and then the hydraulic system powered the belt with no ferromagnetic material whatsoever inside the MRI room itself. And so that meant that they could have the treadmill immediately next to the MRI scanner, just like we do in the echocardiography laboratory. So there's essentially no distance between the treadmill and the MRI table. And so we'll kind of come back to how that performed when we get to the next section on clinical populations. So that's treadmill. The next option is bicycle, which we can achieve. There are units available, commercially available units, where you can have a bicycle ergometer that attaches to the end of the table, and that's what you're going to see behind me on my virtual background. We have one of those units. There's the advantage is that they're stainless steel and aluminum based, so you don't have to worry about the ferromagnetic materials interfering with image quality or becoming a projectile into the magnet. They're commercially available. They're expensive, of course. It's very sophisticated equipment, but you can control the workload. And so, as with a bicycle unit that we might use in the exercise laboratory traditionally, if the patient pedals a little bit of a faster cadence, the resistance eases off. If they slow down a little bit, the resistance goes up a little bit, so that you can prescribe the workload. If you say you want them to work at 50 watts, the machine will constantly adjust so that they're always achieving 50 watts, and then you can escalate it. You can have a ramping protocol, whatever you want to do. The other thing is that you can have immediate image acquisition. They're already supine positioned on the table, and so if they're of a certain height or really leg length, you can exercise inside the bore of the scanner. If they're a little bit too tall for that, what we've been doing is letting them reach steady state of their exercise. You pop their feet out of the pedals, have them straighten their legs so they don't bump their knees on the top of the scanner bore, and then slide them in quickly. And we're usually able to start image acquisition within 7 to 11 seconds, and then certainly finish it well comfortably within a minute. The disadvantage is that it's supine exercise. It's a little bit different than upright exercise, and it does focus because the body is sort of fixed and positioned. Patients aren't able to recruit as many muscle groups, and so a lot of it is focused on the leg muscles, and you can have quadriceps muscle fatigue. And then if you are having them exercise inside the bore of the scanner, there still can be a little bit of rocking motion as they pedal on the bike, especially depending on how high of a workload you're prescribing for them. And so you can see some motion of the thorax, even though they're supine. And like I said, this is our unit that we use. We've got these handlebars that the patients can hang on to try to prevent them from shifting on the bed too much, on the table too much while they're pedaling, and they strap in so they can use both muscle groups. And this is this is actually me inside the board of the scanner. And this is one of our research participants' images on the right, where you can see at rest, low-level exercise, or a moderate intensity exercise. You can get very crisp images. And as with other things within the MR environment, you are not restricted to limitations of acoustic windows. And so things like the right ventricle or the atria, you have pretty much an unobstructed view, well, including the left ventricle itself, where sometimes with things like echocardiography, you might struggle to see a consistent acoustic window between rib spaces when the patient's breathing hard, or hopefully they don't have lung disease that further, obstructs your windows. You don't have those problems with CMR. You got very good visualization. And in terms of supine exercise, the bicycle is sort of the most commonly one that's been deployed, but there are other ergometers out there that are available. There's a step ergometer where you sort of push repeatedly back and forth with your legs. There's an up-down ergometer. I think actually the knee is not usually bent with this. It's sort of a up-down motion that you make on the ergometer. The more you move from left to right on this figure, the less the full body moves, and so you gain some advantage with reducing thorax motion, which helps with your image quality, but you then further limit your muscle groups that are being used during the exercise, and so you have a higher risk of skeletal muscle fatigue before you really push their cardiovascular system to their limits and provoke a robust physiologic response. So it's just the give and take of choosing different exercise modalities in the CMR unit. And along those lines, if you just think about 3 different exercise modalities, so upright treadmill, which of course is our clinical standard usually in the exercise laboratory, upright bicycle, which is another option, and some of our clinical patients even choose this if they tend to cycle a lot and for exercise, and they think they can get a better challenge out of the bicycle ergometer. And then supine bicycle, which is what we usually use in the CMR environment. So the treadmill, of course, is physiologic, is reflective of ADLs. Like I said, there's lots of clinical validation and familiarity with this test. And the patients are most likely to achieve a true maximum test in general, not always, but in general, especially in America, where the prevalence of regular bicycle riding is much lower than other parts of the world, like Europe. And so the danger is that you put someone who hasn't ridden a bike in several years on a bicycle ergometer, and they might have skeletal muscle fatigue long before they really reach the cardiovascular limitations otherwise. So the upright bicycle, the nice thing is that you can easily prescribe workload. The EKG tracings during this are very clean compared to what we're used to on the treadmill. But there is reduced skeletal muscle recruitment during this form of exercise and a higher chance of skeletal muscle fatigue. And so in general, again, this doesn't apply to regular cyclers, but in general, the peak VO2, the peak oxygen consumptions that you get from an upright bicycle test tend to be about 80 to 90% of the treadmill value. And then finally, you have supine exercise, which is what we need to use in the MRI environment many times. And again, you have even lower skeletal muscle recruitment, a reduced leg perfusion pressure gradient, and a reduced peak heart rate that's provoked by supine exercise. And so in general, you get a peak oxygen consumption that is only about 2/3 of what you get on an upright bicycle test. And so when we look forward to using this in the clinical population, sometimes there's a bit of a concern that this might not be an adequate physiologic challenge to maintain sensitivity for something like, say, ischemia in patients with known or suspected coronary artery disease. Although some of the data that we have actually suggests that's not a valid concern, that we do have very good sensitivity, so we'll kind of get to that. But in general, these are the considerations. So when you see something like a peak VO2 value from a supine bicycle test, you know that these numbers are in general going to be lower than the upright test, and you need to sort of take that into context. It's a little bit apples to oranges. And then there is the option for isometric exercise. We've been talking about aerobic exercise, but Isometric exercise is nice because it allows for a constant workload without any movement of the thorax. And with this approach, you can provoke several changes in central hemodynamics and coronary blood flow. So options for this are you can have a hand grip ergometer, where some of the groups that have used this have had a visual feedback system where they basically they see what the maximum grip strength is of the participant, and then make it so that they maintain whatever it is, 40 to 60% of that grip strength constantly. And if they start to loosen up a little bit, the visual feedback system kind of tells them you need to squeeze a little bit tighter. If they're squeezing too tight, it tells them relax a little bit. So they maintain this isometric challenge. Another similar approach is using a biceps pull. This is just sort of a rudimentary pulley weight system, which has been done before, and again, is some percentage of their maximal effort. Or I think the most uncomfortable one to look at is weights applied to the ankles, and then they sort of do a leg lift and flex their abdominal muscles and try to maintain that as long as it can during imaging. Yeah, it's been done. So that being said, we've talked about the different exercise challenges. Now, what imaging sequences can we use? I think, of course, the immediate one that we might want to reach for, that our group has used the most, has been cinematic imaging, which, up at the top is the rest phase, at the bottom is our exercise phase. These images during exercise, so we're using a compressed sense, real-time imaging technique. Usually what we do is apply, it waits for some trigger, either a QRS complex on the ECG strip or a pulse wave peak on the pulse oximeter, and then it triggers imaging in real time to acquire a cinematic sequence at that slice offset. And you just make your way down the entire length of the left ventricle from base to apex, and this is one of the earlier experiences. So there's a decent amount of image artifact, but if you slow this down and just go slice by slice, I think it's what I tend to find is that for all its shortcomings and little bits of image artifact, compared to the stress echocardiography laboratory, I think the visualization is still quite good and superior to echo. And within the base of the LV, you get usually about 3 slices, and so you got a few different cracks at it, even if one slice offset is not the best. And you can contour it to look at things like augmentation of LV stroke volume, which is something that we do in a lot of our research studies. And so again, I showed an example of this already, but you can look for wall motion abnormalities, failures to augment segmental systolic function with an exercise challenge. And here's an example of one where in the infraseptum there's a lack of augmentation. You can also do flow studies. Actually, some of the earliest studies using exercise CMR from the 90s were flow studies. And so if you position it over here, the proximal ascending aorta, you can do that during rest and then exercise, and then you can apply a region of interest and on your phase contrast images and look at augmentation of ascending aortic flow, in this case with low level exercise, and see that the red in the stress is a larger volume in general than the blue at rest, and you can sort of calculate forward stroke volume in that manner. You can do perfusion. As I mentioned, the group at Ohio State really was able to achieve this very well. This is an example from our lab where you have the first pass perfusion at rest, at exercise, and in this case there are no perfusion defects during exercise. But if you had a patient with one, you could identify that pretty well. You got to be careful about when you're doing that, and so you have to make sure that if you don't see a regional wall motion abnormality, that you're still close enough to the exercise termination point to be maintaining an adequate sensitivity for ischemia. And then you can, if you have the right sequences or you've got the analysis software, you can apply contours on this to try to get a quantitative assessment of myocardial perfusion, maybe look for perfusion abnormalities that are difficult to see with the human eye. So here we have this contoured out in a somewhat rudimentary fashion using circle CVI. And then there are groups that have used T1 and T2 parametric mapping sequences with a diaphragmatic motion sensor that can be obtained immediately after exercise. We'll go through some of that data in a little bit. So that being said, how has this been used in clinical populations? So just to start with, healthy subjects, most of this techniques that I mentioned were sort of calibrated on healthy subjects, or at least they formed a control group compared to patient populations. This is one of the studies looking at the percentage of peak VO2 that you achieved on a supine test compared to upright. And like I said, it kind of hits right there at about 2/3. You can get about 2/3 of an oxygen consumption with supine exercise that you would have gotten with an upright test. And they looked at imaging patients during exercise, 0 to 4 seconds following the completion of exercise, and then 60 seconds post-exercise. And you can see that, between immediate exercise and 4 seconds, there's not too much of a difference. You start to get out to that 60-second mark, and certainly there's a difference compared to rest. These are the red dots compared to the black dots at rest. There's a difference compared to rest, but there is a decay that you're experiencing already in healthy subjects. So they have a pretty good recovery compared to some patient populations. But nonetheless, it kind of gives you a little bit of a profile of the differences in sensitivity, looking at different time points following exercise. And they did a meta-analysis of what changes are experienced in healthy subjects with exercise. And what they found was that the change in left ventricular end-diastolic volume with supine exercise across the board was very, very consistently about 0. They didn't see augmentation of end-diastolic volume, no real changes in LV end-diastolic volume, but there was a very consistent across studies in healthy populations, a reduction in LV and systolic volume, which meant, of course, an augmentation of stroke volume and ejection fraction. And I really just think it's remarkable how close these confidence intervals line up across studies. Is just sort of a reflection of the precision of CMR and using an approach like this. And what you'll notice is that there's one that is kind of an outlier. This study right here, and right here, it seems like the magnitude of change was so much greater in this one study. Did they do it wrong? The answer is no. It's the only study that used a treadmill. And so it sort of shows you a little bit the magnitude of changes that they achieved, the physiologic response that they achieved with a treadmill-based study, as opposed to supine bicycle ergometer, which was used in the other studies. Just sort of food for thought in people who are contemplating a clinical or research protocol of their own. If you expect your findings to be subtle, then maybe a treadmill challenge is the way to go after all. Okay, so that's healthy subjects. What about in patients with coronary artery disease, either known or suspected, which is usually why we're referring, or this is one of the most common reasons to refer for a clinical stress test. So again, this is Dr. Hundley's study from just over 20 years ago, where they had at that time a small number of individuals, but in looking for the performance of this exercise CMR with the treadmill outside of the scanner room for detecting coronary artery stenosis greater than 70%, they found a sensitivity 79%, specificity 85%. But then when they again, later on, when they had more patients as a lab, they had more experience in performing these tests. They were able to achieve imaging within 60 seconds in 90% of individuals, and they found that their tests had prognostic value. So those with no signs of ischemia, meaning no EKG changes or wall motion abnormalities with exercise, in general had fewer composite events compared to those who did have signs of ischemia. and so and there's a trend towards even cardiovascular death and non-fatal MI. The Ohio State group, again, they're the ones that position the treadmill inside the scanner room. They performed, I think, a very clever study where they were able to simultaneously do a exercise CMR study and a SPECT myocardial perfusion imaging study, all with one exercise run. So basically, they would inject the radioisotope at rest, do the rest nuclear imaging, and then they would bring them over to the MR unit, perform the rest CMR imaging, then start their exercise stress protocol inside the MRI unit. When they reach peak exercise, they would immediately inject the radioisotope and immediately lay them down for stress CMR imaging, and then let them recover, get their recovery imaging, move them back over to the nuclear unit and take their stress nuclear imaging. So one exercise test, immediate side-by-side comparison of SPECT MPI versus CMR. And what they found was that with treadmill stress CMR, we'll take the patients with no ischemia on the test. Still, 3 of them went for cath, I presume because they had positive SPECT studies, and none of those patients had a stenosis greater than 70% on cath. The patients with ischemia present, 4 of them went for cath. I'm not quite sure why these 3 did not, but of the 4 who went for cath, 3 out of 4 were found to have greater than 70% stenosis. Comparing this to the SPECT cohort, I think probably the scariest one is to follow it down along the ischemia absent line, and you see that 4 of those individuals went for cath, and they missed one. They missed someone with a greater than 70% stenosis, and this was that case where here's the CMR imaging at I believe this is exercise imaging cinematic. This is the first pass perfusion. We can see there's very clearly a perfusion defect in the circumflex territory. There's no leg gadolinium enhancement, and sure enough, there's a flow limiting stenosis in the ostial circ that was completely missed by SPECT imaging, and so it sort of is a nice display of the sensitivity of this modality. Not to mention the fact that they did have EKG changes, which we can also get. We could just get an ETT that's combined within this exercise CMR protocol. And then they expanded it with the EXACT trial to 3 additional centers. They made additional units of their custom treadmill, shipped them off to these additional units, and so now they had 94 patients spread across 4 centers, and everybody had some confirmation of their coronary anatomy. If they had a positive test, they had invasive angiography. They had a negative test, they went for coronary CTA to confirm it. And what they found was in the top row is exercise CMR, where they had a sensitivity of 79%, specificity of 99%, very high positive and negative predictive values, compared to SPECT imaging, where the sensitivity was only 50%, specificity was 94%, much lower positive predictive value and a reasonable negative predictive value. So in general, it sort of beat out SPECT and its overall performance. And you might say, well, the CMR is so expensive, it's still not valuable in the clinical setting. Their cost analysis would argue otherwise. So this was total cost if you look at the imaging test itself, plus based on Medicare reimbursement rates and downstream testing, like additional coronary angiogram that would be prompted by a test, and general SPECT is associated in the green is associated with higher total costs than CMR, with the thought that CMR is more likely to get it right the first time and prioritize the patients for cath who actually need it. This is a study that was done out of Singapore where they looked at patients with angina and at least one cardiovascular risk factor who had been referred for invasive angiography. So they knew they were going to get their coronary correlation, and they did a supine exercise test, a supine bicycle test, where it was a ramping protocol. So they went up 25 watts every minute, and they stopped briefly at each minute for cinematic imaging, and then went on to the next stage until they maxed the patient out, at least as much as they could do in the supine bicycle modality. And then again, all patients underwent cath and if needed, FFR. And they found that their predictors of who did have an obstructive coronary artery disease was presence of peak of late gadolinium enhancement, peak cardiac index achieved on the test, regional wall motion abnormalities, and perfusion defects. And so if you looked at sort of the clinical model based on who was predicted to have had coronary artery disease in the black, adding exercise stress CMR in this manner with a ramping supine bicycle exercise test in the blue and red lines really had very favorable receiver operating curves for identifying those patients who were about to be discovered to have coronary artery disease, obstructive coronary artery disease. And so really, if you just stuck with regional wall motion abnormalities, perfusion defects, and LGE, which is kind of the basis of most of our clinical studies, that was in the blue. If you added in this peak cardiac index, you got a somewhat modest incremental value. That's not usually part of our clinical workflow. This is a study that was very interesting, where they looked at parametric mapping after exercise. And so they had healthy subjects, 28 of them, who did the top protocol, and then patients with coronary artery disease who had been referred for SPECT imaging. And they had them do supine bicycle exercise, and they ran T1 and T2 maps on them. And in the healthy subjects, they actually did it twice. They exercised them, ran T1, T2 maps repeatedly to see what the decay of the signal was, and they exercised them again and did T1, T2 maps again. And so what they found was that this was the T1 values, native T1 values. Here they are at rest. With exercise, they went up, and then they had a decay approaching back to baseline, and then you exercise them again, they went back up, and then they had another decay. T2 maps, on the other hand, started here, rose a little bit with exercise, and then sort of stayed elevated for a long time. And I don't know exactly what the interval was between termination of exercise and this third scan, but then they could exercise again, and they maintained high. And so you can imagine to yourself the advantages or disadvantages of both of these. T1 values have a pretty predictable decay, and so you might think to yourself, well, that means I've got a short time frame to image these patients following exercise. But then again, if you're in a research protocol, that might be advantageous. You exercise them, check the T1s, let them recover, do some intervention, like give them a shot of nitroglycerin, and then do it again right there on the table while they're still there. They have a predictable rise and fall. T2 values, you can't do that. But then again, you've got a much longer window that you can image them after exercise. So we always feel so constrained by this 60-second time limit, where if we image patients beyond the 60 seconds of exercise termination, we might lose our sensitivity. With a T2 based imaging approach, that might not be true. You might have a much longer window to look at patients. And so they built these T1 reactivity maps. So this is resting T1 map on a 17-segment model, exercise T1 values, and then the T1 reactivity. How much did it augment with exercise? And then here in a healthy subject, there's pretty uniform augmentation of T1 values throughout the LV myocardium. Take that in contrast to a patient with LAD disease, where you can see a blunted rise in T1 values with exercise in the expected LAD territory. So very interesting pilot data. I'm sort of very interested to see this be developed further. This is a study that Allison Hayes and her group did at I believe Johns Hopkins, and they were using isometric exercise. So they had a hand grip ergometer, and their focus was identifying the coronary artery and imaging it in cross section with phase contrast imaging. So they're actually looking at flow through the coronary artery with and without isometric exercise. And they found that in the white bars, these are changes with isometric exercise in healthy individuals. So the area of the coronary artery went up, the velocity of flow down the coronary artery went up, and the amount of flow down the coronary artery went up just with isometric grip exercises. They can produce these challenges just with a hand grip ergometer. Take that in contrast to a patient with coronary artery disease, where actually the opposite was found to be true. They had a decrease in coronary area velocity and flows down it. And then they did it again where where they gave them a dose of nitroglycerin. And in the patients who were healthy, had mild or severe CAD, they found that there was a robust response to nitroglycerin that they could see with hand grip ergometer. So very interesting study. Again, when you have a very focused and quickly decaying response to an exercise challenge like this, it lends itself very well to repeated imaging in the same session with some sort of quick intervention like nitroglycerin or whatever drug you're choosing, as long as it has a rapid onset, to test some very interesting hypotheses. Let's skip over this one. And then we'll move on to congenital heart disease. So this is actually some of the earliest studies. This is from 2001, where they looked at flow up the ascending aorta in patients who had undergone atrial correction of transposition of the great arteries. And they found in the patients versus controls, there was a significant difference in flows following exercise. They turned it to patients who had a total cavopulmonary connection and imaged all parts of the Fontan circulation and found that they could image through the left and right pulmonary arteries, the SVC and IVC, and map out differences in flows with different levels of exercise here. And so they saw the greatest ramp up, as you might expect, with exercise in the IVC flow as a result of increased flow being shunted down to the lower extremities and fueling the skeletal muscles that are undergoing workflow. Interestingly, they looked at in patients with transposition of the great arteries with atrial correction, they looked at the differences in response between exercise versus dobutamine, which is typically considered a decent surrogate for exercise. And it's not exactly physiologically the same, but we think it's a good surrogate in the right patients. And I put red bars around some of these changes, like end diastolic volume, end systolic volume, EF. This is exercise versus dobutamine. And you can see that there's a discrepant response in these particular patients between exercise and dobutamine. And so it does throw a little bit of a cold water on pharmacologic approaches and show that if you're looking for true physiologic changes that are experienced during day-to-day activities of daily living or whenever the patients are symptomatic during exertion, the pharmacologic surrogates might not be showing you what you think that they are. We'll move on to congestive heart failure. So this is a study with Dr. Hunley's group where they looked at exercise in patients with heart failure, both with reduced and preserved EF versus healthy controls, and looked at not just flow through the thoracic aorta, ascending and descending, but flow through the superficial femoral artery too, to see when there was an augmentation of central flow, did it appropriately shunt down to the skeletal muscles as it should? And what they found was the superficial femoral artery had a significant difference in augmentation of flow between the healthy subjects and the heart failure in elderly subjects, suggesting that there's a problem with the peripheral arterial shunting of blood to the skeletal muscles. And so, the question of these patients with heart failure, why do they have trouble exercising? Surely in a number of individuals, it's problems with central flow, with the heart pumping the blood out. But in a number of individuals, and as this study would suggest, there might be a very prominent peripheral component as well, where the peripheral vasculature fails to augment flow to the skeletal muscles, and that's sort of what this was demonstrating. I think this one was a very interesting study. Again, this is this group out of Singapore. They like to use exercise assessments of cardiac index and what cardiac index could the patients achieve. And so in this study, they took patients who had low ejection fraction and or a dilated left ventricle. And we see these patients sometimes, and we wonder to ourselves sometimes, is this low EF or is a little bit dilated? Is this okay for this individual patient? It's just a little bit down. They tend to exercise a lot. Maybe they've just got an athlete's heart. So anyway, they took these patients who had questionable, I guess, stage B heart failure, and subjected them to an exercise CMR and genetic testing to see if there's any genetic cardiomyopathy. They were all asymptomatic, and they had additional 100 healthy controls to establish what normal exercise responses were. And so they set this percentile cutoff at the 35th percentile, meaning that the patients who did the test, if they didn't achieve at least 35th percentile of exercise capacity that they should have, which was established with the 100 healthy controls, that was considered an abnormal response. And what they found was that on the right are patients who had no genetic mutations. On the left was patients who had a confirmed genetic mutation predisposing them to cardiomyopathy. So in essence, if you could achieve greater than a 35 percentile response to exercise and cardiac index, then there was essentially no chance that you would have a genetic mutation. Whereas if you're below that mark, there was a pretty high prevalence of genetic mutations predisposing to cardiomyopathy, suggesting that this low EF and or the dilated LV is indeed something they'd be concerned about in those individuals. And then this is one of my favorite studies personally, the HFpEF stress trial, where they took patients that we oftentimes see in the clinic. They have undifferentiated dyspnea and some echo signs of diastolic dysfunction. They had an ED prime greater than 8. And so they had dyspnea on exertion. They underwent exercise-based right heart catheterization, and then immediately underwent exercise CMR within a short time frame. And so based on the exercise, on the right heart catheterization, they categorized these patients based on their filling pressures. They either had cardiac dyspnea, and since they all had normal EFs, that meant by definition they had heart failure with preserved ejection fraction because they had elevated pressures during their right heart catheterization, or they had non-cardiac dyspnea because their filling pressures were normal throughout the entire exercise right heart catheterization. And so this is their flow chart. I put this up only to highlight this right here where they were referred for CMR imaging. And so many of these patients, so in this case, 7 individuals were screened out because they were found to actually have signs of cardiac coronary artery disease, amyloid, hypertrophic cardiomyopathy, valvular heart disease, things that, of course, CMR is uniquely positioned to identify. But once they excluded all these individuals, they had their 2 groups. Exactly half of them ended up being diagnosed with HFpEF, half of them ended up being diagnosed with non-cardiac dyspnea. And this is the chart. I won't try to identify that. But what was interesting is when you set up the receiver operating curves, so between the trying to identify those people who did have cardiac dyspnea, or in essence HFpEF, left ventricular longitudinal or long axis strain had a very poor ability to categorize these patients at rest and okay with exercise. It had an area under the curve of 0.76. But left atrial strain actually already at rest had a pretty decent discriminatory capacity of an area under the curve of 0.82. And when you exercise these individuals, now suddenly the left atrial long axis strain had a very pronounced discriminatory effect with an area under the curve of 0.93. And so, in essence, they had 2 different profiles. The patients with non-cardiac dyspnea were able to augment they were able to augment their left atrial function during exercise compared to rest. And the patients with HFpEF had a blunted or absent left atrial augmentation with exercise. And these tended to correlate with the filling pressures obtained during right heart catheterization. And then I just throw this one in there because I can't help but talk about this study. It's just so interesting to me. The study of mental stress. This isn't exercise now. This is mental stress, where the study just amazes me that they were able to pull this off and get through an IRB. But basically, they had this study protocol where I don't remember exactly what they told the participants they were doing. I think they told them they wanted to see the response to doing math equations. And they said, okay, there's going to be a series of arithmetic equations up on the screen. You don't have to get them all right. I mean, just do your best. We want you to do at least as well as your peers. And we'll have this scale up here that tells you how well you're doing compared to a peer group. And so the participants would lay down in the scanner. They'd have headphones on. They were playing a high tempo music track through their headphones that was stress inducing. Anytime they got an answer wrong, it would go very loud and unpleasant noise played in their headphones. And then no matter what, the software was designed to make it look like they were doing worse than their peers. So they would start to dip into the red. The investigator team would come onto the speaker and say, hey, just a reminder, just you have to do at least as well as your peer group. You're kind of slipping a little bit here. So it would get that mental anxiety going. That the participant now knew that everybody in the room knew they were slipping into below peer levels and would keep going with it. They would keep doing poorly, and then they would collect and they would do an imaging protocol, a CMR protocol during this very cruel experiment, and collect salivary cortisol levels to make sure that they were indeed stressed out. And so you can see by the salivary cortisol that they did stress them out. Their cortisol went up a good bit during this experience. And then they imaged them. They did a cinematic and real and phase contrast imaging through their aorta to assess the cardiovascular response to this mental anguish. And interestingly, they found an increase in heart rate, increase in systolic and diastolic blood pressure, not too much of a change in stroke volume compared to rest, not insignificantly changed. And so their cardiac output went up, but it was all related to increase in heart rate. And so their blood pressure went up, but again, it was related to systemic vascular resistance changes. So I just thought that was an interesting study. And again, I can't imagine trying to get it through our IRB. Okay, I'm going to move quickly because we're getting toward the end of the session, but we can combine exercise CMR with other modalities, including an invasive right heart catheterization. So Andre Lagersh and his team have really been pioneers in the space of exercise CMR, and they perform simultaneous exercise CMR with right heart catheterization, and found that there was a very, very high correlation of CMR derived cardiac output and right heart catheterization derived cardiac outputs. And so they went ahead and labeled this a new gold standard for ventricular volume quantification during high intensity exercise. You can combine it with cardiopulmonary exercise testing, and the advantage of this is that if you have the Fick equation where oxygen consumption is equal to cardiac output multiplied by the AVO2 difference, well, we can break this apart into stroke volume and heart rate, which we can easily get with CMR. And then if you have a cardiopulmonary exercise testing setup, you can get this VO2 with CPAD, and then you can solve for the AVO2 difference and do things like try to identify peripheral impairments in oxygen extraction. And so this has been done before. We have a unit here. This is someone participating. You can see the little tube right there stuck inside the participant's mouth, and they're breathing through it during exercise, gaining gas exchange. We have this cord going through the umbilicus, passing into the control room where it's hooked up to a metabolic cart, so you can obtain the gas exchange information, and you might be able to see the reflection of Justin Canada in the mirror here, in the window here. He's sort of the mastermind behind setting up these protocols at VCU. I'm going to start skipping ahead. You can do spectroscopy with it, and then I'm going to go a little bit more quickly. I think this was an interesting study that, Dr. Hundley's group did this study looking at cross-sectional views of the coronary artery and looking at responses to exercise. And based on a relatively small number of individuals, they had such high precision between two exams that they were able to run a power analysis that said they would really only need 24 subjects in a clinical trial to detect a 20% change of coronary blood flow, maintaining 80% power. And so they then set up an even more aggressive study based on these power calculations, looking at estrogen supplementation and or atorvastatin in postmenopausal women and effects on coronary blood flow. And so, only 64 subjects, but because of this sophisticated study design and the precision of exercise CMR-based measures, they were able to maintain a good power in this study. Okay, I'm going to keep going and then move on to conclusion. So, in conclusion, deploying exercise CMR techniques can be logistically and technically challenging, but many groups have overcome these challenges with a variety of exercise and imaging-based approaches. I think hopefully you'd agree that exercise CMR offers some unique non-invasive physiologic assessments during a state where patients are most likely to be symptomatic. I think we have some areas that are left to be explored, such as non-contrast based tissue characterization, T1, T2 maps, atrial function, AV valve dysfunction, and then diastolic function, I think is something that needs to be tackled with the CMR and with CMR in general. And then hopefully we'll see that it may find a growing role as a biomarker as a research endpoint or evaluating clinical patients as they respond to therapy. And if this was interesting to you, there were a couple of review articles that came out right at the same time. This one was published in JCMR, and then we published one in Journal of MRI. So both kind of had different approaches to attaching the subject matter. And with that, I'll go ahead and stop, and I'm happy to take any questions. And Shannon, I'm going to stop sharing. Would you mind showing the CME slide? So Dr. Conta said it'd be interesting to repeat it while working in EPIC. You mean the exercise CMR, the clinical protocols?
The mental stress one. Maybe we get a more robust response than math equations. I did want to make one comment about the heart rate or the time limit for obtaining images. 60 seconds is a very good guideline, but as we've all seen, or those who do stress echoes or any type of stress, it can be quite variable from patient to patient. Sometimes you have 90 seconds and sometimes you have 30. So it's, we tell the sonographers, and it would be pertinent apropos to any type of imaging like this, to get the images as fast as you can, because you do have the potential for missing ischemia. I think that's what's even more interesting about the MRI ones, that if you have similar limitations, that the heart rate may drop off, the sensitivity was still better than stress MDI in some of those cases.
Absolutely. No, it's a great point. I mean, especially those subjects, the healthy subjects, or even the patients who develop coronary artery disease despite regularly exercising, they can have such a rapid heart rate decay that, yeah, we just try to rush as quickly as possible to get the images started and finished. Mariah says, thanks. In your grants and manuscripts with exercise CMR, what's the most common critique or question you get? I have to be honest, we haven't gotten too many critiques. I think it's still such an uncommonly used technique that maybe a lot of people don't have experience with it, or if you're comfortable raising critiques. I think one thing that we always are cognizant of is that if you can exercise people and image simultaneously, that gets around the whole issues with heart rate decay, but it also allows you potentially to have some respiratory correction and only accept the cardiac cycles that occur and end expiration. And so Andre Lagersh and his group, they've got some protocols where they'll image at each slice offset. They do 4 cardiac cycles, and then they only choose the one that they can tell when the heart is translating through space. They can tell when it's down at, or when it's up at end expiration, and they'll only use that one in their calculations to try to mirror end expiratory measurements that we make with other techniques. We found that, because we have to interrupt exercise and image post exercise, that we don't have that luxury. If we obtained images 4 cardiac cycles at every slice offset, we'd be spilling into 2 and 3 minutes. And so we haven't done that. We've done more of a free breathing approach. I think we have a very good rationale for why we do that, but I can see that becoming a question in the future. And certainly some groups have even had participants breath hold following exercise, which I don't know how they achieve that, especially if you have a rigorous exercise protocol that you're asking them to do. All right, well, we're just beyond time, so we'll go ahead and close out the session. This, next week is actually a case sharing day, so if anybody has any interesting cases that have come through their lab recently, we'd really love to see them. Feel free to reach out to me or Shannon, and we'll look at getting a schedule built out for next week. We usually do about 3 cases, and we'll see everybody then.